Now, when a patient is presenting in the emergency department with chest pain or chest heaviness, and one suspects that there can be ST elevation MI, then this is such a dangerous diagnosis, such a fatal condition it can prove, that first of all, doctor should actually take care of the ABC of the patient. Like when a patient comes to the emergency department with the chest pain, because these patients can sometimes be so unstable that you will have to have a look at the ABC value of these patients. Uh, though it demands a separate video because it needs to be explained and discussed in detail, but talking briefly, A stands for airway. Airway is related about with the conscious level of the patient. Like GCS is Glasgow Coma Scale. If a patient has got a GCS which is less than 9 by 15, then there are chances that this patient will not be able to take care of the airway, and you will have to pass the endotracheal tube. I still remember a patient which we managed a few days back in our ICU. That patient presented with ST elevation in the lead 2, 3 and AVF. Patient was received in ICU, and when we started managing, suddenly patient started having difficulty in the breathing. So we had to immediately pass the endotracheal tube and start ACLS because patient was having asystole at that time. So take a very good care of the GCS of the patient. If it dropping and it goes less than 9 by 15, immediately pass the endotracheal tube and you may need to put the patient on the ventilator. When about B is breathing. Breathing is first you look at the rise and fall of the chest if someone is drowsy, and you will have to look at the saturation of the patient SpO2. SpO2 is the percentage of the hemoglobin which is saturated with the oxygen, and if it is less than 94, you will have to put patient on the oxygen, and it even can be on the very lower side if patient has presented with shortness of breath and patient had MI and developed cardiogenic shock or the cardiac failure. Then you will have to do the chest auscultation, and if it is full of grafts, then you will have to give oxygen, may need to pass the tube and may need to put the patient on the ventilator. But if chest is clear, you will have only to give oxygen if saturation is dropping. So C is circulation. From the circulation, I mean the pulse and blood pressure. You will have to check the pulse of the patient. If you can feel it, then you will note the rate and the rhythm of the patient, be it tachycardia, bradycardia, and rhythm, whether this is a regular rhythm, sinus rhythm, or atrial fibrillation or SVT. And by just checking the pulse, you can actually have some idea about the rhythm of the heart beat, and rate tells you about the tachycardia and bradycardia. Immediately blood pressure of the patient is checked, and if it is less than less than 90 by 60 and chest is clear, you can give a small bolus of normal saline like 100 ml, because heart maybe is compromised, so you better not give much fluid and you start inotropes. But if there are grafts all across the chest, you will never ever give fluid, only you will start inotrop. So before you start the other management of the ST elevation MI, you will have to take care of airway, breathing and circulation of this patient. So this is important to know about the ABC. So one thing which is very important to be understood in the management of the ST elevation MI is that in cases of the ST elevation MI, the culprit coronary artery is completely occluded. There is no flow of blood at all. In cases of the unstable angina and non-ST elevation MI, there was incomplete occlusion of the coronary arteries. But in cases of ST elevation MI, there is complete occlusion of the coronary arteries. So the only viable option available can be lysis or breakage of that clot which is occluding the blood flow across the coronary arteries. So Mona B is not an option here. So Mona B, which we used in cases of the unstable angina and non-ST elevation MI, cannot be used in these patients of ST elevation MI. Why we cannot use this? Because Mona B was used in those cases where coronary artery was partially occluding the blood flow. But here in ST elevation MI, blockage is complete and blood flow across the coronary artery is completely occluded. So the only viable option is fibrinolysis, breakage of the fibrin clot. No other option. Mona B not an option. There are two types of the fibrinolysis. One is the pharmacological fibrinolysis and the other one is the interventional fibrinolysis. The best option is always to go for the interventional fibrinolysis like PCI, percutaneous coronary intervention, but because of the non availability of this option or because of the cost issue, most of the time pharmacological option is taken up. But in our setups in for example in Lahore, we have a very famous government hospital of the PCI, and in the private setups we have doctors hospital which actually provides this interventional fibrinolysis. From the interventional fibrinolysis we mean that we break it through the PCI, which I'll talk later on. So there are two options: pharmacological fibrinolysis and interventional fibrinolysis. No other option available. Mona B is not an option. You cannot wait for the troponins. No formality of having cardiac enzymes, troponins, because whatever management you are to do, be it the pharmacological or the interventional, you have limited time option, because pharmacological option should be taken up within the first hour of the presentation of the patient in the hospital. When the patient enters into the hospital, that is known as the time to enter the door, and when you start the pharmacological option with the IV line, this is known as door to needle injection. It should be well within the 60-minute time. Within that 60-minute time, injection should be started. And when a patient comes to the emergency department, it enters the door, and once the patient is decided to undergo PCI, this is known as door to balloon time. That should be within the 90 minutes. So this is a very important factor. We cannot wait for the cardiac enzyme. So whatever options we are to choose, we are to choose within that time. Now if we look at the pharmacological options here are pharmacological fibrinolysis. The door to needle time should be less than 60 minutes. Whenever a patient has entered into the hospital, that time is known as door. And when the pharmacological option, which is obviously is attempted through the needle or IV line, that is known as the needle time. Door to needle time should be less than 60 minutes for the best result of the management of the ST elevation MI. First of all, we should always rule out contraindication to the fibrinolysis, because these injection can cause problem in those patients who have got certain risk factor or contraindication. There should be no intracranial hemorrhage. There should be no bleeding diathesis, like there should be no derangement of the INR, PTA, PTT, and there should be no recent CPR more than 10 minutes in any patient, and patient should not be having a brain tumor. If there is no major contraindication, menorrhagia is a relative contraindication, and platelets less than 100,000 are relative contraindication, but these are the absolute contraindication where fibrinolysis should not be given. In the fibrinolysis, we have got two options. Unfortunately, one is known as the poor man's injection and one is known as the rich man's injection. Poor man's injection is also known as streptokinase or SK. This is fibrin non-specific and can cause the allergic reaction is given second time in patient's life. It is cheaper one and is known as poor man's fibrinolysis injection. The rich man's injection is the tissue plasminogen activator. For the most famous is Alteplase, and it is costly but easy to be given, and it can be repeated in the lifetime of the patient without allergic reaction. Streptokinase injection is 1.5 million units. This is famously known as SK in Pakistan. 1.5 million units are in one injection of the streptokinase. This is dissolved in 100 ml normal saline. It has got a very specific way of making this injection. No bubbles are allowed to be generated in the vial of the streptokinase injection. Then it is started slowly and is given in 30 to 60 minutes, because streptokinase causes hypotension. So one needs to be very watchful regarding the blood pressure of the patient. It should be checked every 5 minutes, And if there is a hypotension during the process of giving a streptokinase, better either to stop it, or should be a patient should be started with inotropic sport or a bolus of 100 ml or 50 ml normal saline. So this is a specific way of giving streptokinase injection. Now, second option is Alteplase, which comes with the brand name of Activase, and it is a tissue plasminogen activator. It's a costly injection, and it is used less often in Pakistan because of the cast tissue. But it is a very clot specific injection, and it does not causes bleeding as much as the streptokinase cause it, and it can be repeated in the lifetime of the patient because it does not cause the allergic reaction. It's a 100 milligram injection where 15 milligram of it is given in the bolus form in the 2 minutes. Then rest of the injection is diluted in 100 ml normal saline. The next 30 milligram is given in the infusion form in the 30 minutes, and the remaining last 35 milligram of the Alteplase is infused very slowly in the next 60 minutes. So total time injection is 1.5 to 2 hours, and this is how the fibrinolysis option, second fibrinolysis in the pharmacological option is given Alteplase with a brand name of Activase and 100 milligram injection. So if a patient is either given the streptokinase or the tissue plasminogen activator Alteplase, how can we know that our injection has worked actually? And patient who presented with the ST elevation MI has got the success of the injection and now has improved as a result of injection. There are two things. First, chest pain of the patient should resolve. There should be resolution of the chest pain, and the height of the ST elevation in the initial ECG and the ECG which we do after 1 hour of the injection. There should be a 50% reduction in the height of the ST elevation. If this elevation of the ST segment decreases in height 50% or more, and there is resolution of the chest pain, then we will call it that our injection has been a success. But say if it doesn't work, if patient hasn't got any relief of the chest pain and there is no change in the height of the ST elevation, then our injection has failed actually. In that case, we will have to go for the interventional fibrinolysis or PCI, percutaneous coronary intervention. But this form of the PCI is known as rescue PCI, not the primary PCI. So PCI is again the option, but here it is known as rescue PCI. But if there is a resolution of chest pain and height has gone less than 50%, then it's a success. The second option in the management of the ST elevation MI is the interventional fibrinolysis. It's a superior option because the person who's actually carrying out this procedure knows that the coronary artery has been actually cleared of the thrombus, and so there has been recanalization of the coronary arteries and circulation has been restored. It has got a limited availability. It's not available everywhere, as I already told. In Lahore, we have one option in the government hospital of PIC, Punjab Institute of Cardiology, and in the private hospitals we have famously in Doctors Hospital and Umar Cardiac Hospital. These are two very famous hospitals which provide catheterization facility to these kind of patients privately. When the patient enters the hospital and the time when we start the procedure, this is not the needle, it should be balloon. So it's the door to balloon time, because when we do the angioplasty, we use the help of a balloon which we inflate and we get rid of the thrombus. So door to balloon time should be less than 90 minutes or 1.5 hours for the optimal results. When the patient enters the hospital and when the procedure starts should be less than 90 minutes. So there are two types of the PCI. PCI is percutaneous coronary intervention. PCI is the procedure through which we do the interventional fibrinolysis. It is one is primary PCI and one is rescue PCI. It has got higher success rate, and primary is the one when a patient enters into the emergency department. We get the ECG. It shows the ST elevation. Doctors write right away knows that patient is a case of ST elevation MI, there is a facility of catheterization and patient is shifted to the PCI, and the first attempt is of PCI. This is known as primary PCI because primarily the doctors decide to go for the percutaneous coronary intervention. But if pharmacological intervention is attempted first and it doesn't work, as I already told, if chest pain is not resolved and if ECG does not show the decrease in the height of the ST segment equal or more than 50%, then our injection or pharmacological intervention failed. We again then have the option to go for the PCI, but this time this is known as the rescue PCI, to rescue the life of the patient, to rescue the myocardium. So in the interventional fibrinolysis, what we do in the PCI, percutaneous coronary intervention, it is attempted either through the radial artery or femoral artery. Most of the time it is attempted through the radial artery, and catheter is passed. First the artery is actually engaged through the cannula, then a catheter is passed through the cannula, and fluoroscopically it is guided all the way up to the aorta, because the coronary arteries are exiting from the aorta just outside of the aortic valve, and blood enters into the coronary arteries during the diastole. So a contrast is injected which goes actually all the way into the coronary arteries and outlines their anatomy. Because we give contrast injection, so we need to have urea and creatinine of the patient, and if there is a problem with these, so it becomes a contraindication of PCI. When coronary arteries are outlined, then we can actually know where is the thrombus because of the filling defect. This process is known as angiography. Angiography is actually taking the picture or knowing the route or anatomy of the coronary arteries and localizing the thrombus present in any of the coronary artery. So once angiography has been performed and the location of the thrombus in any particular coronary artery has been defined, then through the same cannula another catheter is passed with a balloon tip, and once fluoroscopically guided that catheter reaches near the coronary artery where the thrombus was present, then balloon on the tip of that catheter is inflated, and in this way that thrombus is initially broken down, and there is a suction method through which the broken pieces of the thrombus they are sucked into the catheter and taken out of the body. So that balloon, it causes the recanalization of the coronary artery, and this process is known as angioplasty. So PCI is the combination of angiography and angioplasty. Angiography is a process of taking the picture of the coronary arteries or knowing the exact location of the thrombus in a coronary artery, and angioplasty is process of repairing that coronary artery. But there is always a risk that that recanalized coronary artery can either develop another thrombus or can actually again have a blockage somehow. So in order to prevent that thing, angioplasty is always nowadays accomplished along with the stenting. Certain stents, these are titanium stents, drug eluted and non-drug eluted. They are placed in that area where there was a thrombus in the coronary artery, and the aim of placing a stent along with the angioplasty is to prevent the recurrence of the occlusion of the coronary artery. So this is the PCI, percutaneous coronary intervention, which is a combination of angioplasty and angiography and angioplasty. Now if on the angiography, the findings are that it's a triple vessel disease or double vessel disease, but with the two major arteries, for example LAD and right coronary artery, or there is a difficult anatomy of the coronary arteries and there is a risk of arterial rupture during the procedure of angioplasty. Then the option would go to the CABG, which is coronary artery bypass graft. What happens in the CABG, that we take either the saphenous vein from the legs or the internal mammary vein from the chest, and then we place a graft between the aorta and the affected coronary arteries. For example, in this case, if you look at here, this is left circumflex artery, which is good. This is left LAD, which is left anterior descending artery. It is also fine, but you see there is a thrombus present in the right coronary artery. And what we do, that we take this saphenous vein and a small saphenous vein, and then we place it. We actually anastomose it between the aorta and the RCA past the thrombus area. So this is how we do the bypass surgery, or the cabbage coronary artery bypass graft in these kind of patients. So now there is a very important question there, that there are certain diabetic patients who, because of their diabetic neuropathy, they do not feel the chest pain. So sometimes in them the acute coronary syndrome goes undiagnosed, and there are some patients who either present very late, outside the window of the door to needle and door to balloon of 60 and 90 minutes respectively, or there are patient in some patient fibrinolysis does not work and it fails. So how can you, by looking at the ECG, you can tell that patient in the past had any myocardial infarction? Normally, the Q wave, which is formed in the ECG leads because of the septal depolarization, is less than 1.5 millimeter in depth. This is known as physiological Q wave. But in those cases where patient had myocardial infarction in the past, they couldn't either get the treatment or the treatment failed, but somehow they survived that attack. In those patients, there would be deep Q waves. When I'm saying deep mean they are more than 1.5 millimeter in depth, and one small box in the ECG is 1 millimeter, so they are more than 1.5 small boxes. They are known as pathological Q wave. For example, if a patient comes to you in the emergency department or in OPD, and you in routine get ECG, and there is deep Q wave in lead 1 and AVL, we called it old lateral wall MI. And if the pathological Q wave, which is deeper than 1.5 millimeter in depth, it is in lead 2, 3 and AVF, this would be known as old inferior wall MI. And if the pathological Q wave is in lead V1 to V6, we will call it old anterior wall MI. If it is in V1 and V2, we will call it old anteroseptal MI. V3, V4, old anterior wall MI. V5, V6 have pathological Q wave, we'll call it old anterolateral MI. Other than ECG, there is another way of diagnosing the damage to the myocardium, that is through the echocardiogram. Echocardiogram is the ultrasound of the heart, and you see the walls, those walls in whose coronary arteries had the thrombus. They would be either hypokinetic, they will be moving, but the movement will be less than the normal. These wall can be akinetic, these wall will not be moving at all, and there either can be the dyskinesia. Like during the systole, they are supposed to come inside, but during the systole they may be moving out, and there is a dyskinesia, or you can say in complete movement of the heart they are behaving differently. Ejection fraction can be calculated, and ejection fraction is calculated with the end diastolic volume and end systolic volume ratios. And if normally it is always more than 55, but those patients who have got myocardial damage because of the myocardial infarction, they have ejection fraction less than 55, and most of these patients fall in the category of ejection fraction of 35, 30 or 25 or 40%. Ejection fraction tells you that how much blood, when it enters the heart, is thrown out of the heart to the rest of the body during the systole. That percentage is power of the heart. So this actually completes the topic of ST elevation MI and its management.